Hello everybody, my name's Erica and I'm a Year 3 student midwife. Today I'll be teaching you all about placental examinations. My target audience will be first years for this presentation. Objectives for today is for you all to understand and gain an insight into what placenta is, understand how to examine a placenta after delivery, recognizing when to escalate abnormal findings, and other views and faiths to placenta. So I want to begin by asking you all to just write down 2 things you know about the placenta, could be any 2 things, and I'll give you 5 minutes to do that and you can share that with the class. What some of you know about the placenta, which is a really good start. So we hope that at the end of the lesson here, we add a bit more to your list that you have just written down. So as you can see here is an image of a fetus and the placenta. So the placenta is the large organ presented on the right side over here, and you can see the uterus lining just around the baby, and the placenta is attached to that uterus lining, and it's formed throughout the pregnancy. So all nutrients and oxygen can be transported through this cord, which you can see a thin line running around the body of the baby. Of the placenta. So some people refer to the placenta as the baby's lungs, and this is because it provides the fetus with oxygen and nutrients through the bloodstream via the cord. If you remember, we saw in the previous picture on the previous slide, I showed you the cord that's around the baby, and that's where that exchange of oxygen and nutrients happens. The placenta also protects the baby as it gets rid of all the harmful substances, acting as a barrier, and also produces hormones such as estrogen and progesterone, and this really helps with fetal growth. You may be wondering why we actually have to check a placenta. So we have some standards of proficiency for midwives, which is a clinical guidance that indicates as practicing midwives and student midwives, we should be identifying these things. So as you can see here, I've highlighted it in yellow just so it's clear for everyone to see. The midwife's role in assessment, screening and care planning. And one of the main bits to note is the completeness and healthiness of the placenta and membranes, and any suspected abnormalities associated with blood loss. Now, I've left the link down below for anybody that wants to read a little bit more about this, and it's under Domain 6. Continuation of why we examine the placenta. So we mainly conduct this placental examination just to check for its completeness. So as we saw in the guidance before, it does mention that we as midwives and practicing midwives should check the placenta for completeness. So you want to first start off by ensuring that the placenta is of normal shape, size, smell and consistency. An easy way to remember this, when you first look at a placenta, think triple S. Is a very easy 3-letter word that you can look at the placenta and automatically think SSS. Stands for shape, smell, size. We examine a placenta to detect for any abnormalities, again, which was mentioned on the guidance before. And adding on to the completeness of the placenta, we need to make sure that the membranes are all intact. If not, it may lead to infections and blood loss, which is referred to as a PPH, so postpartum hemorrhage, which is a blood loss of more than 500 milliliters. This will give you a clearer anatomy of the healthy term placenta. So as you can see here, the placenta is usually a disc shape. Now it's typically round, and it's normally around 15 to 20 centimeters in diameter, and it does have 2 components. So the component along the top side is the fetal side, and there you can see the amnion, you can see the umbilical cord, you can see the vessels in the umbilical cord as well, and then along the bottom 2 images here you can see the maternal sides. The maternal sides consists of about 15 to 20 cotyledons, and the placenta as a whole is about 2 to 3 centimeters in thickness. So if you do get a chance to look at a placenta in practice, Make sure you look at both sides. We will be going into each side in detail, so the fetal side and the maternal side. I will keep this slide on for a few minutes for those that would like to draw the placenta, the anatomy of the placenta, if you do find it easier to memorize things by drawing and labeling. So keep this up for a few minutes and we'll move on to the next slide shortly. Each component of the placenta. We'll begin by talking about the fetal side. So as stated before, SSS is the acronym you want to have in your head whenever you do look at a placenta at first glance. Shape, smell, size. The fetal size is 15 to 20 centimeters in diameter, as mentioned before. The outer layer of the placenta on the fetal side is known as the chorion. This area is typically shiny, grey and translucent. If you do feel it, if you do have a chance, try and feel it on placement. Ask your mentor, is it okay if I just have a look at the placenta and see if you can have a feel and observe the fetal side? This side, you will see some vessels running through into the placenta as well, and the cord attachment site should be visible. Now, the size of the placenta can vary with every fetus, so some placentas are smaller than others and some placentas are bigger than others. Now we'll look at membranes. So when you do check a placenta, you want to check if the membranes are ragged or complete. The membranes that surrounds the uterus is known as the chorion, which is pointed out here on the image on your left. This area known as the chorion helps with the exchange of nutrients, gases and wastes between the embryo and the mother's body, as mentioned before on the functions of placenta. So again, in the image, I have arrowed and labelled where you can see the chorion and where you can see the amnion. When you are looking at the membranes, it's important to look for extra holes or lobes or extra vessels, as these can be abnormalities that may need to be escalated. Just a reminder that the images that will be shown are a little bit graphic, so if you do feel a bit squeamish, you can feel free to just pop out for a few minutes and come back in. For those that are still here, we'll be discussing the cord. So it carries oxygen from the maternal circulation to the fetal circulation. It has 3 vessels to do this effectively, and a way to remember this is AVA. So you will see 2 arteries and 1 vein. So the vein has the big role of transporting oxygenated blood from the maternal circulation to the fetal circulation. As you can see on the image on the right, I have labelled it as red to signify oxygenated blood. It's the largest vessel out of the 3, as it works a lot harder by pumping oxygenated blood into the fetus. Then we have 2 other vessels known as the arteries. I have labelled this in a picture as blue, as it gets rid of deoxygenated blood and waste as well. It does this by carrying the deoxygenated blood and waste from the fetus to the placenta for it to then be excreted. So it's really important you check these accurately, as it can easily identify how well the blood flow was from maternal to fetal. Now you may be wondering, what is this grey shiny thing that I can see that's surrounding the vessels? This is known as the Wharton's jelly. What the Wharton's jelly does, it provides structural compression support of the vessels, as well as protecting and insulating the umbilical cord. The maternal side. This is the side that's attached to the wall of the uterus during pregnancy, and it's divided between 15 to 20 lobes known as the cotyledons. This side is almost always red or maroon in colour. Some may actually describe it as the meaty side of the placenta. So when you look at a placenta, you need to ensure that the placenta is complete with no missing cotyledons. So you want to do this by holding the placenta in the palms of your hands with the maternal side facing upwards. You should look really carefully just to ensure if all the lobes are present and they fit together. As it's in your palms, you can also squeeze it together just to see if it pieces up like a little puzzle. You shouldn't notice any missing cotyledons. If you do, it's likely that that piece is still inside the uterus. This is very detrimental for mum's health because it means the uterus isn't able to contract as well as it should, which is more likely to cause bleeding and infection. So if you do look at a placenta and you think there's a missing cotyledon there, make sure you escalate it to your midwife or a senior midwife or a doctor on call, just to make sure that they can look at the birthing person and do further investigations. It's also important to just check the bleeding on the birthing person as well. When checking the maternal side, it's also worthwhile to have a feel of the placenta because you can come across gritty placentas, which is commonly found in those that smoke during their pregnancy. However, it's also found in non-smokers during pregnancy as well. The professional term for this is known as calcification. And in non-smokers during pregnancy, this is a common part of the maturation and aging of the placenta. Preparing to examine a placenta, you must speak to the family at an appropriate time or read their birthing plan about what they actually want to do with the placenta. This is because some people choose to bury their placenta, take their placenta with them for encapsulation, some are happy for the hospital to get rid of, and also some opt for lotus births, which we will discuss in the next slide. Sometimes samples and swabs are required from the placenta, but before you do that, it's important to gain consent from the birthing person. As the code states on 4.2, you must gain consent before carrying out any action. Make sure you have all your equipment ready, which we will discuss in the next slide. And it will also be reassuring to the families if you explain to them why you are checking the placenta and how the placenta examination works. How do we examine the placenta? So I have a list of equipment here on the right of what you would need. It involves gloves, goggles, aprons, Inco sheet, disposal bag, and a yellow placenta pot with a sharps box and a scale, depending on your trust. So you want to begin by washing your hands using the aseptic technique, and then wear your PPE, including gloves, aprons, or goggles, to protect yourself from contamination. Then place your placenta on an Inco sheet. What this does is just absorb any remaining blood that may be on the placenta or in the kidney dish. At the same time, you would like to remove the metal clamps and dispose of them in the sharps box for safety. So with your gloved hands, you then want to hold the placenta by the cord and allow the membranes to hang over. This just provides a better view to check the completeness of the membranes. Make sure you check that there are no ragged membranes or holes. Then you want to lay the placenta flat with the fetal side facing upwards. Identify the site of the cord insertion. Normally you will find this in the center of the placenta. Whilst you are at the fetal side facing upwards, remember to check for the triple S: size, shape, and smell. Then you want to separate the amnion and the chorion. The amnion is the shiny bit, and it can be peeled from the chorion up to the umbilical cord. After identifying the amnion and the chorion, you want to now look at the umbilical cord for AVA. Can anyone tell me what the AVA was? So, perfect. So the answer is on the PowerPoint. So the AVA was the 2 arteries and the 1 vein. Again, make sure that there are 3 vessels. If you do find 2 vessels or 1 vessel, remember to always escalate it. After you do that, you want to then invert the placenta, exposing the maternal side, remove any clots, and spread the placenta in the palms of your 2 hands and check if the cotyledons fit all together. This just ensures that there is no part of the placenta or membranes left inside the uterus. If you do notice any missing cotyledons or any ragged membranes, make sure to escalate it, as it could lead to a PPH and an infection. Once you get to this point, it's always nice to have a feel of the placenta to feel for any of the grittiness as well. After you check the maternal side of the placenta, make sure you dispose of the placenta or return it back to the families based on their request. If you are to dispose the placenta, place it in the yellow disposal box, or as per trust guidelines, dispose it in the accurate way. Remove gloves and wash your hands. After you do so, document all the findings, report any abnormalities you found, and remember to tell the families what you found as well. You may come across abnormalities when you are examining a placenta, one being a two-vessel cord. As we discussed before, a cord should normally have AVA, 2 arteries, 1 vessel, which in total would mean 3 vessels. Some placentas just have 2. Although this is normally noticed during coloured Doppler scans during pregnancy, it still can be found after delivery of a baby. Babies with 2 vessel cords are at risk of reduced growth, stillbirth, and preterm birth before 36 weeks of gestation. If you do notice this, it's important that you escalate to senior midwife and your clinician immediately, and then send this placenta for histology for further investigation. You may also come across missing lobes or cotyledons, as discussed before. This occurs in up to 3% of vaginal deliveries, but can also occur in cesareans as well. Remember, retained products can mean that the uterus may not contract as effectively as it should and cause bleeding or infection. Remember, placentas vary in different shapes and sizes, so if you are unsure, make sure to ask your senior midwife or a doctor to see if your findings are okay. Any abnormality that you find, it's important that you tell the families what you found and what the next plan is. Histology and pathology testing. Does anyone have an idea of what this could mean? Some great suggestions there, which is really good. What it really is testing the placenta of its tissues and cells, and it inspects abnormalities caused by the infection of placenta. Pathologists can also give us a record of events explaining pregnancies affected by a medical condition such as stillbirths. Every trust is a little bit different. However, some reasons to send a placenta to histologists could be any of these. So stillbirth, late miscarriage, prematurity, intrauterine growth restriction, which is also known as small babies, twins, placental abruption, maternal substance misuse, and 2 vessel cords, as we discussed before. Be sure to check your trust guidelines to see the list of reasons as to when to send a placenta for histology testing. Sometimes we may also need cord gases. This is when we take a sample from the venous and the arterial of the cord, and it gives us an idea of the condition of the baby in utero. So I have a task for you all today. When you go off and when you do deliver a placenta that requires cord gases, I want you to ask your supervisor what is meant by cord gases and attempt to obtain a cord gas sample. Remember, you need a separate needle for the arterial and a separate one for the venous. Also, try to complete an e-learning just to widen your knowledge on cord gases. In practice, we will come across different cultures, faiths, views, and religions. We have to recognize as professionals that not all families would like to clamp and cut the cord after 1 minute of pulsation has stopped, or for us to discard the placenta after examination. Some families opt for what we call a lotus birth, whereby the placenta is delivered with the baby and remains attached to the baby until it decays and falls off naturally. It works very similarly as to when we do cut the cord, and we do advise the families that the cord will fall off between 5 to 10 days or 3 to 10 days. It is still our duty to examine the placenta, although the family would wish for lotus births. Some doulas suggest that by having a lotus birth leads to the baby having a calmer attitude, a better supply of oxygen, and a stronger immune system. So some families like to do what we call an encapsulation, which involves drying the placenta and turning them into capsules for consumption. We still have to examine the placenta just as we would any placenta. The only difference is that we will return it back to the families as opposed to disposing it in a yellow bag. The families often take this to private organisation who would dry the placenta for a few days and put them into capsules. Although there isn't many evidence to support the benefits, we still have to continue and empower women in their decisions and what they would like to do. The only time we may not return the placenta back to the families for this is if there was significant abnormalities or an infection during labor that will require further examination, also known as a histology, as we discussed in previous slide. Some families would like to bury their placenta. This is more common in the Islamic practice and West African tradition. We would continue to examine the placenta just as we would do every placenta, explain the findings to the families, and return it back to the family. We always have to remember that birthing people have a right in their choice of care. So if they would like their placenta back, we must encourage and empower them, as stated in the NMC. To test your knowledge a little bit more, I would like you in groups or in pairs. I'm happy for all of you to do either. Just to note down 2 to 3 points about what you know about the placenta per area. So I have drawn a little diagram of a placenta just as a hint, but I want you to give me a little bit more. So I'll give you about 5 to 10 minutes to discuss this, and we will come back together. I also have a quiz for everyone to complete, so I'll give you all about 6 to 7 minutes to complete these 5 questions. You can discuss amongst yourself, and we'll share the answers shortly. Does anyone have any questions at all? Well, thank you for listening to my presentation. I hope you all have a great day.